Next, I'd like to introduce Dr. Laura Cacciaguerra. She's going to talk a little bit about the next subject.
Hi, hello everyone. Thank you very much for the invitation. I'm very excited. So I'm a bit nervous because this is a stage. I don't have anything covering me. I'm from Italy, so we'll see if what they say about hand gesturing is true or not. So I'm gonna talk a little bit about how MOGAD can affect the brain. I don't have disclosures. I think the first question is how common brain involvement is. So we've heard from Dr. Chen that actually the most common presentation in both children and adults is the optic neuritis. But indeed, if we look at the charts here, you see that the brain is fairly commonly involved too, especially in children. So one of the presentations that you might have read about is ADEM, which stands for acute disseminated encephalomyelitis. And this can be a presentation of MOGAD in 41% of kids, but also in adults. I mean, 1 out of 2 can have ADEM as well. We can also have some brainstem and cerebellar involvement. This is more rare, but if we sum up these all, you see that actually about 1/2 of the children can have some brain involvement, and also 1 out of 5 adults. So this is the brain, you know it. I just thought maybe it would be nice to have some definitions of what when we talk about the brain. So the cerebrum represents the majority of the brain, and you see that highlighted in the light blue here. So if you imagine to cut this brain and just have a look from up of it, this is what we actually see. This is like a transverse cut of the brain, which is very similar to what we observe with the MRI. And the words that you see there are those that are more related to the most commonly affected regions of the brain during a MOGAD attack. So we have the cortex, which is the outermost layer, that sort of ribbon that goes all around. We have the thalamus, which is kind of the core of the brain. You see those 2 areas really in the middle of the brain. But we also have the white matter that can be involved, and it's a sort of a highway connecting the different regions of the brain. Then we have the brainstem and the cerebellum. So this other region of the brain can be involved as well. Now we cut it once again, and this is what we see. I just highlighted among all the regions the pons and the cerebellum because they can be affected, like in a good percentage of cases, so you might encounter that. What do they do? Well, the cerebellum and the pons are those areas that are deputed to the control of the balance, of the coordination of your limbs, but also of your eyes. So we will talk more about the symptoms that we can have if these areas are affected. But also, this is not strictly the brain, but sometimes we have described these very recently. We can have some inflammation of the meninges, which are a sort of membranes that cover the brain and protect the brain. How does it feel when you have brain inflammation? I thought that, of course, like people with MOGAD are the best source of information. And this was a survey conducted by the MOG project a few years ago. So you see 24 people responded to this survey. And actually, you can have a lot of symptoms with MOGAD. Highlighted are those that can somehow be linked with brain inflammation. So this is why when a person comes and has some symptoms, first time you see the nurse and she will ask, so what symptoms do you have? And you go through all your story. And then after 15 minutes, the resident or the fellow comes and they will ask exactly the same question. Then third round comes the consultant, and here we go again. But it's just because based on the symptoms, you can somehow have hints regarding which part of the central nervous system is involved. So if it is more the brain, the optic nerve, or the spinal cord. There is some overlap, but you see here, for instance, a patient with headache, a patient with some numbness or weakness in the leg, in the arm, with walking difficulties, with seizures. All of these symptoms kind of direct us towards having a look to the brain. So the first type of manifestation that I will be talking about is the ADEM, so the acute disseminated encephalomyelitis. So you see here the areas of the brain that can be involved. We have been talking about them before. Just as a reminder, so sometimes we see in the history of the patient that infections or some vaccinations can precede this event. This is the definition, like the medical definition. So you can have many symptoms altogether. As Dr. Chen was mentioning, it does not only involve the brain, but sometimes you can have also an involvement of the optic nerve or of the spinal cord. There must be some unexplained encephalopathy. So what does encephalopathy mean? This means more that you are really like off from a standpoint of your cognition, of your behavior. So usually the family are like the great source of information about this. We can have some sleepiness, especially in children. Sometimes I read through the charts, like parents say, oh, you know, they really love playing softball in the afternoon. They are very into sports, and now they kind of prefer going to sleep for a while. So just to remember that, so thalamus, that area there, in Latin means bed. So when that is involved, you might have some sleepiness and you may want to go to bed. The MRI is very talkative. We can have a lot of signal in there, and we will see some example. And as we've heard before in the patient journey, so during ADEM, we can have a coma, so it can be very severe, and 3% of the people with ADEM can go to the ICU. So this is when ADEM happens, usually the physicians are very, very, very proactive. So now the involvement of the brainstem or of the cerebellum. So once again, we see the picture here. So usually, it is very rare to find it in isolation. It can happen in the context, for instance, of an ADEM or for more like multifocal symptoms of the brain. You see just the 6% that we've seen before. Which are the main symptoms? I would say the imbalance, the lack of coordination, but also the double vision, because when your eyes are not perfectly in coordination, you can have some difficulties. So for instance, people will say, oh, you know, it was really hard to read, not because I was not seeing, but because I felt like the letters were a little bit off. We can also have, we said, meningeal and cortical inflammation. So the cortex is the outermost part. So this type of manifestation was very recently coded in medical language. So we used to call that FLAMES. It's an acronym for what we see. Now we use the term of cerebral cortical encephalitis. It doesn't make much of a difference. This just means that we have an inflammation that mainly involves the cortex, so the outermost part of the brain. We can also have an inflammation of the membranes around the brain, as we heard, so meningitis or meningoencephalitis. In terms of symptoms, there is a sort of spectrum. So if you think we have just an inflammation of the membrane, so the outermost part, you don't really have much in terms of very specific neurological symptoms. You can have headache, you can have fever, but as this inflammation goes down to your brain, you start having seizures, there can be confusions, there can be cortical symptoms which are really overt. For instance, people can have difficulties with speaking, cannot find their words, cannot understand when people talk to them. And this is what we see during brain symptoms. So these are some examples of the MRIs. You see on the top the MRI, and down there is a sort of cartoon of the areas where I would like to focus your attention. So when you hear lesions, we don't actually know exactly what is going on there, but we see a lot of white signals. So usually the parenchyma, the brain, looks gray. And when we see this area of like a high brightness, a lot of contrast, this means that there is some inflammation going on there. So these lesions have a very typical appearance. So like having an MRI during the acute phase is very informative to us. They are usually poorly defined. They look a little bit like clouds. And you see the areas mainly involved. So we see the brainstem, the cerebellum, but also the thalami in the third picture, and the cortex. You see how that can be very inflamed. So most of the times the physician will order an MRI without and with contrast. So why is it that we ordered the contrast? Is it because the contrast can be informative as well? So even if we don't see any white matter changes, any lesion, any hyperintensities, like in the left part of this picture, in the top row, we can still see some very subtle enhancement, some brightness you see in the sulci of the brain. It's a sort of spectrum, so from like a very, very mild abnormality on the MRI to the most overt MRI changes on the right side. And this leptomeningeal enhancement, this is the way this is called, is actually very informative, can discriminate between people with other types of brain inflammation, multiple sclerosis, neuromyelitis optica, and it's pretty common. Up to 46% of people with MOGAD and brain enhancement will have a sort of a leptomeningeal inflammation as well. Now, this is an example of how the story of a single patient can change our perspective on a disease. So again, what do we see during symptoms? So this person had headache, eye pain, sleepiness, the legs could not really move. Then they had an MRI, and we cannot see those white spots that we expect. Then after a few days, this person is really disabled, it's in a coma, no limb movements at all. And at the MRI, we start seeing some subtle changes, some subtle white abnormalities. I hope that you all can see them here. And then this person gets treatment, plasma exchange, steroids, very aggressive. The MRI is a disaster, you see? A lot of white matter changes, a lot of lesions. But actually, this person is alert and is improving. So what does this mean? That the MRI has a sort of delay. There is a lag, and we must be aware of this. So this is more educational for us as a physician, and we are trying to make more people aware of this in the scientific community. This happens in approximately 10% of people with MOGAD, with cerebral symptoms, or with myelitis. The symptoms can be very severe, as we have seen from that single case. But in this case, we can do the cerebrospinal fluid, and in our experience, it does show high cells, which are suggestive of an ongoing inflammation. We can repeat the MRI, and usually these changes, these abnormalities become overt most of the times. Again, next question is, okay, after an attack, no symptoms, what do we see with an MRI? And the answer, once again, is nothing, which is really good. So Dr. Saik-Mazurek has shown here that actually only 3 to 4% of people with MOGAD with no symptoms at all have new lesions on the MRI. And this is just a graphical view of what I'm trying to say. So if the black line is the symptoms detectability, and the red bars are the ongoing inflammatory activity, you see that pretty much all the time, if you feel something, if something is going on, you will feel it. So basically, if there is no symptoms, the large majority of the time, everything is good. So there is no ongoing inflammation in the brain. Next question is, does the brain fully heal after one of these attacks? Many patients have this question. They are a bit afraid of cognitive issues. So we have been looking into this. But actually, most of the time, patients do pretty well. The only area that can be somehow impaired is the visual spatial processing of information, but we know that there is a lot of visual component in MOGAD. So it can be related at least partially to that. But in any case, there is a correlation with the brain and its wellness. So that's why when we have a relapsing disease, we really want to secure it from subsequent attacks. About other symptoms that sometimes are overseen, once again, the MOG project comes to us with some help. One is fatigue. So this was another survey together with the myelitis patient group. And you see that indeed fatigue Physical and mental is very common. Up to 85% of people with MOGAD can experience that. But also emotional fatigue is there, especially in children. So this can be important for caregivers and their family. And finally, I want to conclude with a positive note. So we have talked about these lesions. They can be pretty big, pretty overt. We have an example here of the brain. Down road is the spinal cord. But actually, if we repeat the MRI when the person is feeling well, no more symptoms, you see that all or most of those lesions completely resolve. So there is this phenomenon that we call lesion resolution. We do not really observe this in patients with other disorders. We have talked about neuromyelitis optica, about multiple sclerosis. It occurs, we have been measuring that. We think it occurs after at least 3 to 4 months since the onset of the symptoms. There is no effect of age, so both children and adults can have this phenomenon. If you get like acute treatment with, let's say, steroids, plasma exchange, immune globulins, this helps. But indeed, 50% of the lesion will resolve regardless, which means that this is part of the natural history of the disease. And again, Dr. Cacciaguerra saw that the resolution of at least 2 lesions can discriminate between people with MOGAD and people with MS. So this can be also important for the diagnosis. So is this remyelination? We are starting looking into this. Usually the MRI that you get in the clinical setting have a power, a strength of 1.5 to 3 Tesla, which is the magnetic field strength. These are MRI usually done for research with a very high field strength that let us see not only the lesion, but also some microstructural features of the tissue. And we have analyzed, you see, over 100 chronic lesions in people with MOGAD and in people with MS. And interestingly, we found that there is more myelin even within the lesions that stay in people with MOGAD. So remyelination might contribute to this phenomenon. And so to conclude, the brain involvement is common, especially in kids. The symptoms are very variable. We can have motor, sensory deficits, double vision imbalance, but also confusion and headache. The MRI can show lesions, but can also be normal in the beginning. Many people have fatigue. Some people can have some cognitive symptoms. But lesion resolution is a phenomenon that we observe in people with MOGAD, not in other diseases, and might reflect some mechanism of remyelination. Thank you all for your attention.